hold it off the skin for you and keep it in place and so on, and then a little plastic covering over the top. But I don't know that we have those at the School of Nursing, so I'm going to make my own as if it doesn't exist. This is an IV start kit, and an IV start kit has in there one of those. It has a new Tegaderm, a new clear dressing, and notice there's a thing to be able to put on there to label it and so on, but it has a brand new tourniquet, was what I was trying to say, plastic tape, because this is water we're dealing with, right? So it helps to have plastic. An iodoform, an alcohol and a chlorhexidine swab and a gauze. And so, I guess I'll open one. I wasn't when I was going to put my own together.
So these would be like sterile gloves?
Yeah, you're going to be wearing gloves for this process, right?
Does it have to be sterile gloves?
I'm going to say this for you, and I'm actually going to make my own kit here. And this is an IV kit. This is very typical that they have these little Rubbermaid things with extra supplies. And nurses, when they start an IV, don't usually just head out with a couple of things. You take this kit because stuff happens, and you need more stuff, and you don't want to be running back and forth, running back and forth, running back and forth, and so on. So I'm going to set up my supplies. What's missing in here is that I need something to attach to the IV once I have it in place. And so this is non-sterile, but it would be in a sterile pack, right? And I'd have to open it up. And this is a saline lock, all right? I could have called it a heparin lock if what the facility policy was to actually add heparin to it to prevent clots on the catheter and so on. And it's just a semi-permeable membrane. We shouldn't be sticking needles through here, but those needleless devices can hook in here. Once I'm ready to go, I need this all ready to hook up, and it needs to already be filled with solution. Does that make sense? Because otherwise it would be shoving this amount of air into the patient, and air embolism is one of the complications outside of infection when you access somebody's vein. You don't want to get air into their veins. A large amount of air will travel through their body, land in their right heart, fly up against the pulmonic valve, right? And no blood will get from the right heart to the lungs. Therefore, no blood will go to the left heart, right? It's a sudden death kind of situation. So it takes a lot of air in general. It takes like 10 or 15 cc's and so on, but that's why we keep air bubbles out of IV tubing and so on and so forth. So I'm going to get my normal saline, and these days normal saline is prepackaged, but I treat it like a med. I'm looking at it 3 times. A lot of the errors that you've heard about with the stars and all that kind of stuff was because somebody rushed in the dark, grabbed a vial, pulled it up, thinking it was a flush solution, and flushed an IV with it, and it was actually either insulin or heparin or some other kind of drug, all right? So make sure you're watching yourself. So this would be sterile, so I wouldn't have to swab it the first time, and I would literally just force the fluid through, and it should have, if it was sterile, if I'm pretending it's sterile, I would just leave it in its sterile packet, because this part, which is going to touch the inner hub of the catheter, is going to also touch the fluid going into the veins, must remain sterile. But I leave it ready to go, because the minute I hook it up, I'm going to have to flush it to make sure that it's patent and it's working okay. All right, and so here's the old weird way of doing this if you don't have something like a stat lock. I usually have, and I usually put something under them like a Chucks or a towel or whatever the hospital is currently allowing. And then I take my other gauze, because they're packaged with 2 gauze, and I make what I lovingly call the pillow. All right, so I fold it 2 by 2 like this, and this is to put under the catheter so it doesn't dig into their skin and give them a pressure sore, literally, okay? And that's what's been replaced with this new plastic gadget. If they don't have it, I'm doing it this way, okay? And I park that, and I get it ready to go. And then what I need is I take another, this is 1-inch paper tape, and I rip it in half. So I kind of need 2 of those, maybe 4-inch little tapes to secure it. All right, and I got what I need, and I got my gloves on. And the first thing I do with the patient is I try to negotiate, where do you want this IV? Because if you put it in some place they don't want it, and they call you and they want it off 6 seconds later, you know, it's kind of pointless. And so on. So you can put a tourniquet on down low on somebody's arm, right? Are you right-handed or are you left-handed? Are you right-handed? You go over to left hand. Oh, wait a minute. They have a big sign over their bed saying you can't have a blood pressure or an IV or anything in the left arm. Do you see what I mean? You have to just be sensible. So the first thing I do You know, I haven't got my gloves on, right? Or I could have my gloves on for this, but I'm not even doing the needle thing. And I just tell them I'm looking for a vein, and I'll let you know before I'm going to poke you, all right? So I'm just deciding where I think I could be most successful. If I don't like that, I come over the other arm. I don't like that, I come up here. I don't like that, I come up here. What about the case where I'm doing that and I just really don't see good choices? Like nothing's popping up. What are some of my techniques to be able to get veins to distend and make them more visible to myself? Okay. You could have them do the hand pumping thing. Never been a big hand pumper, but the hand pumping thing. Tartar just gets painful. All right, so it's a gravity thing. One of the things I do is hang their, pull them over the side of the bed and hang their arm down. Another thing is typically people will be cold, and especially in the ER and those kinds of situations, you wrap their arm up in a warm blanket for a few minutes, and up on the floor we can even take a towel and get it wet with warm water and wrap it up with a plastic bag, like an isolation bag. I've done that a few times in my life. You know what I do before I do that, before putting it on tighter? And I worked in an IV team for, when I went to grad school, I covered somebody's maternity leave for whatever reason, and so on. But these old oncology nurses taught me this trick, and it works every time. I swear to God, it works. And that is, they used to say to me, they'd put on one tourniquet. If they didn't see veins, they put on a second tourniquet above it, and they put on a third tourniquet after that. And as one nurse said to me, all God's children have a vein when you put that third tourniquet on. That's the way they did it, because you can't just hurt them. You're going to leave bruises and marks if you put it on tighter. What about the case of the elderly person? And that's rare that I would think you'd have to do that. What about the case of the elderly person who has very thin, friable skin? Sometimes with those people, you put a tourniquet on and you just touch their skin near the vein with a needle, and it blows everywhere. All right, some of those people, we even start them without the tourniquet. They don't need the back pressure, all right? But they aren't going to have the big flash into the chamber to let you know that it's there. So in those people, I actually put a blank syringe here, and I aspirate. Oh, I got blood. Cool, I'm in there. Switch it out and flush and see how I am. Another thing you can do, and I like this better than the multiple tourniquet technique, to be honest with you, and that is to use a blood pressure cuff. So you use a blood pressure cuff, and you pump it up, and you're feeling to see when you've occluded the vein, right? Because you stop feeling the arterial thing. So, and now you figure out where systole is, and then you come down about 20 millimeters below that, because you want the artery to fill the limb, all right, and you want the veins to not empty, and so on. So you could, like if it's 120, you go, great, you put it down about 100, and you just lock it and leave it in place in there. I think that for a lot of people is more comfortable in some ways. Everybody has different skin, and it's kind of weird. Some people have very, very tough skin, and for those people, I really recommend using very short, sharp needles. The smaller a needle is, the tends to be the sharper it is in a way too. And so I use 1 inch rather than, let's see, what are these? These are 1 inch, but these do go up to being 1.5 inches and all that kind of stuff. And I know this sounds really strange, but it has been my experience that red-haired people have the toughest skin. I know that's just sound weird, Zach, and I'm not correct. You don't feel like you have tough skin, no? All right, but that's been my life experience too, and that's what these women told me when I was working with them too. Like they'd say, okay, go up and start it on this person up there and stuff like that, and that person's a redhead. And whether that's, I need to read the literature to see if that's total baloney mythology from nurses or if it's actually evidence-based. I don't care the person's hair color. If they have tough skin, you're going to have your better luck with short and sharp needles. Okay, so now we both agree. Have you ever had an idea? Is it all right if I put you there? And one of the other things that I find completely annoying about nurses is that they discount the patient's information. The patient can tell you about their experience getting an IV, but only if you'll listen to it. So this is what will sometimes happen. The patient will say to the nurse will come in, and the patient says, oh, nurse, first of all, I'll tell you, if you're the IV nurse and you come in with this, it is not like coming in and saying, hi, I'm Jane, I'm your nurse today. Because you come in with the IV tray and they're like, it's nobody's jollily happy to see you. And trust me on that one. But anyway, so they say to you, oh, no, it's going to be hard, or I'm really a tough stick, and so on. And what I immediately say is, okay, can you tell me about that, or what's been your experience about that? And because if they tell you my veins roll, just any variety of information that can be helpful to you. One of the things that they will say, however, because the public doesn't understand, is they'll say, I have no veins. And that's why I think nurses discount them, because they're rolling their eyes in their head and thinking, okay, everybody has veins, and stuff like that. But the other thing that you should know is that our veins are descended at different times. So if they ever rolled into the ER or had an experience where their blood pressure was lower, they had the flu and diarrhea, which is typically why the public will be having IVs, do you know what I mean? Their veins will be very, very collapsed, and they'll have the impression that they have no veins. That's what happened to me. I thought I gave myself C. diff in my last rotation, and I was at Huntington, and they poked me 8 times, unsuccessfully, I might add. It was astounding, and nobody wanted to hear where I thought this IV should go, but it was kind of funny. But if the patient has valuable information, just go ahead and listen to them and don't discount them. And if they don't want it there, but it's your favorite vein, you better do it. Now, when you're a novice at doing this, the rule of thumb is that nurses only have 2 attempts, all right? So if you look down and there is only 1 vein in that body that's possible, and you're new at this, it may not be the one that you need to get your practice on. Does that make sense? Get the most experienced nurse there. However, in the long run, what I will tell you is this is a skill, and like any skill, the more practice you get at it, the better you are. We're working with nurses who punt, some of them, not that they're bad people, but they have chosen not to excel at their skills. Does that make sense? So they just shove it to someone else all the time. And I don't think that's a valuable way to be as a nurse, to be honest with you. The way in which you were saying, am I going to do practicum on this? Well, it's kind of weird. If you go to the hospital and they give you an IV certificate, you don't need a certificate, first of all, separate from your RN license to start IVs. There was a scam going on where new grads thought they had to go out and pay for that 8-hour class when you were an RN. It was ridiculous. You were already licensed to start an IV and so on. But usually what they do is they teach you the class for a day, like in a new grad program. They're going to go through, fluid and electrolytes and blood transfusions and all the reactions and all that stuff. And then you're gonna take you out and they're gonna do 3 attempts. You can even be unsuccessful on your 3 attempts, and they're gonna go, all right, good luck with that, and off you go, kind of thing. Isn't that amazing? It's not. They don't require much. I think it's a problem for us because we don't require much actual competency. Okay, and we should be more competent. People get focused on this like it's some kind of sexy skill. This is just a very small task in nursing, I would tell you, and there are things that I think are more valuable. All right, so let's say I've agreed on this with my particular patient. The way these needles work, I'm just going to show you something about them. So can you see, here's the catheter right there. See that white bit? Do you see what I mean? And you can see how the needle's poking out from that. And so it's kind of like that Foley thing where, when I get blood in the flash chamber, I may only have that little tip in the actual vein itself. Does that make sense? So I've got to go at least a good 1/8 of an inch longer to make sure I'm truly in the vein to be able to thread my catheter. All right? If you put your thumb on top of it like this, you can't see the flash chamber. So, and it's not a big gesture. It's just a little tiny thing like this. All right, it's just a little tiny movement like this. So I'm really highly recommending that you hold it like this, because you tend to be staring at the insertion site and miss the part where you've got blood back in the flash chamber and so on. Okay, so now doing this. This is a 20 gauge 1 inch. Not too bad. We should pull out a bigger one so you can see what the difference is. All right, so I've got my patient. I'm going to use, and frequently it's a little pledget that you break, that you pinch in the middle. And the betadine or alcohol or whatever comes down on a little cotton tip on the end. Don't touch that with your fingers. That's what you're trying to do, sterile. All right, and pick exactly where you're going to put that and go around in a circle. All right, do your surgical scrub. Give it a second or 2 to dry. If it's iodine, so if I was going like this, all right, and it was iodine, and now it's brown, and I can't see my blue vein anymore. We'll talk about the case of dark-skinned people. What many nurses do after that is to take a second alcohol swab and to put it on the vein on top, and you pull down hard because you can be milking more blood into the vein. Does that make sense? And get rid of, get a little swipe of the iodine away so you can see it. Am I making sense? Because it looks like quick tanning solution. All right. All right, so here we go. It's, actually I'm going to move over because I'm sorry, I'm gonna move to this one, because now I can see for that. All right, so I do that, dry, I go like this, that's just my style. All right, and now I warn the patient, you're gonna feel a needle stick. It's just gonna last for a minute. He may have to come in the room, hold their hand on the other hand or whatever. If there's somebody that's gonna move over and get, and move their arm for you, you might have to have somebody come and actually hold their arm and so on. But it's like an intradermal. You're very parallel to the skin. You're not up like this because you're gonna go through it. And it's not a gigantic gesture. It's just like that, all right? And I don't know if my blood is open. It's not open, but if we had it on the pole and it was open, we should start to see. Oh, is it that one? Sorry, wrong one. Okay, do you want to, you can put that up, or you want to open it? Oh, okay, so the blood will start coming back. Now, here's the second part of where students struggle, okay? There are a couple of places where students struggle. And here's the second part where they do. Now what we want to do is slide the catheter forward. There's an overwhelming tendency on students to try to pull the catheter out. It can't be that you're going like this, because you need the stiffness of the stylet. You can actually let go of it and have it be sticking out of somebody's body like that. So over the years, what I've learned to say to students that is, because what happens to me is they do it and they do it perfectly, and now they scrumble it up because they pull the stylet out and the thing won't thread. So I tell the students this: just hold this with the back of your thumb. Don't grip it, because I'm telling you, you will, I know you'll pull it out, okay, and so on. And all you're trying to do is loosen this catheter up right here, this little colored part. Where are you, Betty? Okay, I used to have fingernails. What happened there? Oh, it's happening to me too. Could be. All right, so here's the technique. You just want to slide this forward, flush with the skin. Do you see what I mean? All right, this has to be flush with the skin, all right? But I didn't want to pull the needle out, and I'll show you why. Now what you do is you put your finger down to occlude the vein, okay? But you can't put it where the needle is. There's still a needle in that person's body. So you're a couple inches up. I push on the vein. I let my tourniquet go, all right? I pull this out. This is acting like a cork. It's keeping this, otherwise blood would be spurting out. I take this, and there's usually a cap on the end of it, so I have to unscrew the cap. Now I can, this is should be a needleless needle. It should actually lock. Is it locking? Kind of, sort of. All right. And I put this on. Okay. And now I flush and I'm feeling here. What am I feeling for?
Like going, flowing.
Yeah, if it was infiltrating, if it was not actually in the vein properly and it was infiltrating, what would I feel?
Edema.
Right, so I'd feel cold, edema. It's like I'm given an intradermal, right? So there'd be a big blob of fluid there. That's the case. That's why I had this here anyway, right? I had my little thing. I'm like, oh, I'm sorry, that didn't work. And I apply pressure, and I can take this out and throw it away. We shouldn't be doing that. If I flush, and it doesn't hurt to give them the saline, it just dilates the vein. You with me? So I just could be going and doing all this backing up in the tubing. I can see it. Okay, so I'm giving my saline. I'm going to throw that away. And now I'm going to tape it down. Okay? Don't knock it out once you get it in there. Sorry, it's messy. Okay, so this is the technique. I put my pillow. I'm just calling it that. Don't do circumferential tape. Do you know what that means? Oh. All the way around? Because if they were to swell up, it could act like a tourniquet. Do you see what I mean when you're not looking? So there always should be a several-inch gap. So I do this. Now I want my little... Do you see an upside thing? I thought there was one in there.
No, just gauzes.
Really? Promise? Does anybody have like a little clear plastic dressing? I thought sure I had one. I do. No? Okay, I also want to hook this down. You know what, actually, I'm even going to make this one smaller. Because this doesn't have a stat lock, I'm going to put this in place with what we used to call a chevron. I don't know where we came up with this stuff. Which is like a little V. Does that make sense? I don't want to have any tape over where the insertion site is, because that's where I'm going to be staring for the next 3 days till I take it out and see if there's phlebitis. And this keeps it from pulling out. Do you see what I mean? It's secured in place. I'm also going to want to do that so it doesn't get knocked in any way. I'm trying to put tape over tape, so there's very little tape on their skin. There wasn't one single one? Okay, heck. All right. And so now I put my dressing on, like that. These are like dealing with saran wrap. So, you know how saran wrap goes like that and you're stuck? That's my life. Okay, so I usually like hold it on my hand like that, and I just flop it. Sure, he's kicking me. Okay. Don't put it up on here on the saline lock, because what if you had to switch to, I don't know, blood tubing? I don't know why you would do that, but so you've lost the point of having this secondary connector. Just put it on the needle hub itself. All right, smooth it out on the skin. And see, saran wrap, it doesn't work very well because these are old Cal Stay Away ones. All right, so here it is. All right, is it looking good? Now I fill out my little thing. I say it's a 20 gauge started by Jane Hook. And I put these off to the side. Like, I meet these people and I put them there. I'm like, how did that help me? And now I can't see the site, all right? So put it somewhere off to the side so you can still see the site to be able to see it is. And then you have to put this date and time. Then when you document it, what you're documenting is, and you say, started in the, left brachial vein or whatever it's called, needs to be cephalic, on the first start using a 20 gauge 1-inch intercalf needle because there's a catheter over that, and so on. And that's how it looks. And you could do this a little more secure so it doesn't get bumped. What do you think? Good? All right. So then the technique when you and I are going to come along and give everything is we have to, every time we access something that's going to go into the vein, we swab it with alcohol. The technique for flushing, people were saying to me, can I flush? You can't flush by yourself for fear that you might walk in there, and we really need to make sure you get the air out of the line. But we come by on all unused saline locks, and at least every 8 hours, they're doing this, right? They're putting the saline in and checking to see if it's infiltrated in any way. So we can start doing that, but do it with me or with the nurse. IV medicine, when we get to the point we give IV medicine, it gets complicated because you have to have looked at the concentration you're putting in the syringe, and you have to make sure you're not giving it faster than the rate it can be delivered, and whatever effect it's causing now, you're looking for it. Most of what we're seeing is a lot of IV narcotics, right? And IV narcotics are respiratory depressants, and when you give something IV, it's taking effect frequently about 90 seconds. So they could actually, stop breathing or slow their heart rate down or all that kind of stuff within a few minutes and so on. So, but it's more about the drug itself than just pushing, something slowly. Okay, you want to give it a go? So let's talk you through it.